For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 3, Episode 42 of Surfing the NASH Tsunami. Our look at the role allied health professionals will play in the emerging NAFLD pathways starts now.
This week on Surfing the NASH Tsunami.
It's not the diversity we would like to see with regards to patients and nurses in here, and that will really help us to define what's the target. Maybe we can look at it that way. Maybe it's the physician's way of saying what physicians think is important, and now we got to either do a standalone and look from the other side, or put the two sides together from the very start and revisit that theme. And I think there's a lot of opportunities taking that forward.
I have now changed my terminology, and I don't talk about multidisciplinary working anymore. I'm talking about interprofessional working, because I think that when I speak to medical colleagues, their recognition and definition of multidisciplinary is not as we would see it, which is actually more interprofessional.
Clinicians understand why they're collecting the indicators, they're more likely to be collected. They should be involved in developing the indicators. And you can summarise this in just one word, and that's co-production. You need co-production. That's really important.
Late diagnosis in NASH is very common. That's very expensive. That's very complex. This is where we need to make commissioners understand that early diagnosis of liver disease is within their interest and the patient's interest, and frameworks like this that cross appear to do that.
We need the entire community to come together and not just think about heart disease, not just think about liver disease, because we as patients need more than one therapy, more than one organ being monitored, and more than one answer to our questions.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, and this week's guests, key opinion leaders and health services researchers Michelle Clayton and Stephen Callaghan, and patient advocate Robert Mitchell-Thain, as they discuss the roles nurses and allied health professionals should play in the emerging NAFLD clinical pathways on Surfing the NASH Tsunami.
With an interest in NASH and more broadly fatty liver disease, Surf's Up. And as you notice, I am not Roger Green. You have me hosting today. And today we've got Jörn Schattenberg, Michelle Clayton, Robert Mitchell-Thain, and Stephen Callaghan. So 3 of those you know. And Stephen Callaghan, who's new to the group, is somebody that I met a number of years ago when we were looking at commissioning. And Stephen, by background, is a nurse, but talks about quality and helps devise frameworks. So Stephen, can I get you to introduce yourself, give us 2 or 3 minutes about yourself, and then at the end of it, one fact that most people wouldn't know about you, which is interesting.
All right. Well, first of all, a big thank you really to Louise for inviting me. So I say Steve Callaghan's my name, an independent nurse consultant. I've got about more than 35 years experience in healthcare, and it's quite broad and mixed really. So my background obviously as a nurse, I've got a clinical background, and that's not in liver disease but in accident and emergency. I've also worked in primary care and in the community, and I've done some respiratory specialist work. I have a background in commissioning, so I spent 4 years as a commissioner for respiratory disease for Liverpool, and I was respiratory lead for Liverpool, and I spent another 4 years then setting up a health outcomes unit, and that's where my love of measuring things sort of occurred, and I got a bit obsessed with measuring things, and I've had therapy and I'm much better now. I've also got an educational background, so I used to teach a master's in clinical nursing at the University of Liverpool and a master's module in commissioning at the University of Chester, and for the past 10 years I have had my own health consultancy, and really my job is, as Louise sort of alluded to, I help organisations and individuals deliver on 3 things that matter to everyone, and that is quality, value and outcomes. That's my sort of job. So consultancy is one part of my business. The other side is really about education really and support. So I run a quality improvement academy, a bespoke mentoring programme that's mainly sort of one-to-one, not just health professionals but people working in pharma, and I've also got a number sort of learning modules that are bespoke for clients, really. So I describe myself as a generalist, really, because I dip into lots of different things. And one fact about me, I qualified as an engineer before switching into nursing.
So you can fix all the machinery that gets broken as well. That's really handy.
I actually said that in my nursing interview, which I cringe now, sort of wheelchairs and stuff,
Wonderful. So thank you very much and welcome, and great that you could join us.
Thank you.
We'll start with you, Robert. Give us one good professional or personal thing that's happened this week for you.
That's a great question. That's topical. So we've actually had a couple of abstracts accepted to be displayed at the Global Genes Summit in San Diego in September.
Congratulations.
So we'll be looking at rare disease, which I know is not a NASH thing, but we'll be looking at rare disease, and I'm really, really happy. Good partnerships, patient voice being incorporated, and hoping to lead and show best practice. So great question. Thank you. Pleasure to be here and see you again. And thank you for asking that. Happy face.
And for those of you who've never met Robert's the CEO of the Pbc Foundation, having worked previously for the Global Liver Institute, so comes with a wealth of knowledge and background in patient advocacy. Michelle, one good thing, professional or personal, that's happened to you in the last week?
It's only Monday, so I'm not quite sure what's good that's happened this week so far. I've just come back from annual leave, so I am drowning in emails. One good thing is that I've had another couple of people agree to be chapter authors for a book that Linda Greenslade and I are editing on liver care for nurses and allied health professionals.
Fabulous, and what a topic for you to be on, developing NAFLD pathways with the role of allied health. So Jörn, give us one of your hot topic, favourite thing this week, good or personal, that's happened.
Yeah, so my highlight, obviously, is to be in this esteemed round and get many different views, exchange with you guys on this important topic. But besides that, as you know, I was on annual leave too, and I can feel with Michelle because I've just finished cleaning up my email account, and they keep pouring in. So sometimes you wonder how this is a part of your work, or you want to see patients instead of tidying up your inbox. After holidays, other people are taking their leave, so there's a lot of stuff going around in clinics. It's been busy. I can't complain, and I'm looking forward to record with you tonight.
Fantastic. Thank you. It's always great when you can make it, and it's always great to feel Roger can walk away and actually have a bit of a holiday. We'll judge that when he comes back and he's listened to this, but until then...
Do we know where he is, actually?
I can't remember. He did tell me. It was like a programme name, and I said, but I don't watch that programme. It's something to do on the East Coast, but he's got his family there, because when I spoke to him earlier, he had lots of children running around. And I suppose that's my highlight of the week. My youngest stepson passed his A-levels with an A and 2 Bs, having been sat on by my husband for 3 months to revise. I think my husband's new career direction is going to be A-level coaching in business studies and accountancy. So congratulations to the both of them. So that's my highlight of the week, and trying to take...
Congratulations.
He did really well. He did way better than he expected, which is always a relief. So he's got his university place in Exeter, so he's really looking forward to that. So that's great. And for all of those kids who got their A-levels, and the stress is now over, particularly having not done any exams because of the pandemic. They didn't have to sit exams before, so this is really their first experience. So also to do so well in that way, we're really happy. Moving on. This week is obviously about, and it built from your and Jeff's original thing, the NAFLD Summit that you did in Barcelona, and things that were raised in the audience. Nurses, allied health came up a number of times in the topics. So what we thought we'd do is bring people to look at today as to where is the role for allied health, either nurses, social workers, in the NAFLD pathway as they get developed. I was drawn to an article that Jeff from Lazarus was prime author on, and that you were involved in, along with numerous others, Mary Ranella, Hannes Hagstrom, and other such heavyweights in liver disease. It was about sustainable goals. Now, as we know, and a lot of people don't know in healthcare about the Sustainable Development Goals. The 17 goals, I think they were championed and introduced by the United Nations somewhere around about 2015 as an urgent call for action on health, economy, starvation, all sorts of different goals. All of the countries in the United Nations signed up for it, but you never hear about it in healthcare, even though our country is one of them, your country sector would be one. And what I wanted to look at, I liked the framework that was put together there and the way that it was used. And the article is a Sustainable Development Goal Framework, a guide to multisectorial action on NAFLD through a societal approach. I missed it initially, and that was probably because the Lancet EASL review was out at a very similar time. So, and of course, that took all of the headlines. So what I wanted to do was start off by asking you, Jörn, how much you remember of that process, what it was all about, how it hung on to the Sustainable Development Goals, and use that as a framework, because personally I like them. I just don't think they're publicised enough.
Well, thanks, Louise. I'm looking forward to discuss this here with you. As you rightfully said, the Sustainable Development Goals are written forward by the United Nations, but also supported by the WHO, can be used in many aspects of daily life. Overall, they're thought to strengthen health systems or bring more equity and human rights to different countries. Leaving no one behind is, I think, a larger theme that resonates within the Sustainable Development Goals over and over again. I haven't been aware to them as much either. And the group of public health people where Jeff obviously spends a lot of his time and work in, he introduced this to a group of medical colleagues and physicians and took the SDG goals and applied them to NAFLD, asking the question, those, I believe it's 17 goals and a number of targets that are defined. Of these, how many are relevant for NAFLD? What do we need in the realm of NAFLD, and what needs to be changed in order to make a difference in liver health in respect of the high prevalence of NAFLD we're facing today? So the whole paper is based on consensus, Delphi process. There were 2 rounds of online discussions. This was in the midst of the COVID pandemic that the whole project was started. I think it went for over a year in the Delphi rounds. A number of colleagues that came from different disciplines mostly were invited to participate in those online Delphi rounds by highlighting of those 17 SDG goals, which one do you believe are relevant to NAFLD? The first round was reviewed by the core group, and then a second Delphi round was introduced. And in the end, the final framework comprised of 16 targets, which is about 9% of all the targets defined that we picked and shortlisted and summarized them in the paper to highlight that these are sectors that we believe through that Delphi process are relevant for NAFLD and importantly need to be addressed by politics, by people that develop the research environment funding in order to make a difference in the NAFLD for patients. And to dive in a little bit, I think this was pretty rough, but just to give you an example, there is figure 1, and I believe the paper might not be open to everyone because it's not published open access, but we had a nice figure in there, and maybe we can even share something over the website where there were examples. For example, economic resources was ranked very highly. Of course, concerns around food, malnutrition, including obesity, and then non-communicable diseases, universal healthcare coverage was covered. Something that I found very interesting, and we can discuss this maybe a little bit down the line, were access to green public spaces, meaning you have to provide people with an environment in which they can move freely, exercise if they want, and feel safe and go outside. And as such, you get the idea that these are pretty broad and general topics, but through the Delphi process, it was refined on NAFLD.
I like the sustainable goals. I think you can hang things on them. Do you think that the general lack of awareness in healthcare, because I think SDG 3 is all about healthcare, improving outcomes by 2030, improving the health of the nations, and particularly diabetes, heart disease and mortality. Do you think that the general lack of knowledge of them in healthcare providers is an obstacle? It's all right a government being signed up to them. If they don't get those messages down, we can't design the framework around them to deliver the goals, which is one of the things that I've always questioned about them. If I can't hear about them in a local environment, I can't deliver them.
Yeah, I agree, Louise. In the SDGs, it reads more like health financing and health workforce. So you need to provide nurses and physicians to address that. If you coin that down to NAFLD, you would say you need the awareness with physicians, and I agree. They have to have tools to identify and stage patients. That's in relation to biomarkers. They have to have the knowledge to order the test or to be aware that the patient is at risk. That's more as a part of a continuous medical education. And of course, I've been mostly talking about physicians now, but it extends to nurses and allied health professionals. Awareness is a major aspect here, and taking that forward will be one very important aspect.
May I just come in a moment? Jörn, it's interesting because you're talking about nurses there, but I noticed that really in terms of interprofessional approach, approach for this paper. You have Shearer as a nutritional epidemiologist, but other than that, there are no nurses or allied health professionals in your core committee.
They're not among the authors, you're right. It's something that the paper might have fallen short of, including them. It came out of the medical community, and I think the authors were mostly collected through different healthcare specialities. But I'm aligned with you that clearly the view of nurses in that Delphi round is not adequately given or represented.
I'm not sure it's reflected at all. It'd be interesting. I don't know exactly who your participants were in the Delphi, but there's a real lack of cohesive and collaborative thought in terms of allied health professionals, this interprofessional approach. And I think it's really important. And the other thing, and I don't know whether Robert wants to come in, is where is the patient voice as well?
Sure. Before he does so, maybe give me your view. What are your thoughts on that? If you go talking about SDGs, what's the nurse's view on this?
I would say it isn't just about SDGs. I mean, there are specific liver nurse organisations that are at national level. So there's the British Liver Nurse Association, there's CAN, which is the Canadian nurses, there's EASL, has the Nurse and Allied Health Professional Task Force. There are some very senior nursing figures within the liver community, and I wonder why people are not actually tapping in to these resources. Australia also has their Hepatology Association, and RSLD also has their Nurse and Associate section. Why are these people not being integrated?
Michelle, I'm going to be slightly cheeky here. I'm going to reframe the question, because frankly, why doesn't interest me. What interests me is how do we do it better next time? Because we have a wonderful piece. We have an incredible piece. And yet, Jörn, with every respect in the world, the piece is doomed to fail because we're asking for a multisectorial action without multisectorial participation. And we're talking about through a societal approach. And the last time I looked, patients were part of society. It frustrates me. And I heard in Michelle's voice exactly the same. But I don't want to ask, why didn't we? How didn't we? My question is, how do we make this better? How do we make it more inclusive? So other than claiming to be multisectorial and then having to do the work again, would it not be better to be genuinely multisectorial and to be genuinely going through a societal approach so that we can then stand together with an immensely powerful piece of paper that actually brings together every single view? And Jörn, before we go to give you the opportunity to answer that, my next question is, we have, 18 authors there. And are we really going to have one nurse and one patient? Or could we have maybe 24 professionals who do a job, who come from a different viewpoint, with a different perspective, with a different professional knowledge, who come together as equals to create a more powerful paper? I'll breathe now. Sorry, Jörn.
No, don't apologize, Robert. Michelle, points well taken. I think the paper as it stands is a multisectorial call brought forwards by physicians. Totally aligned with you that the perspective of patients and nurses is among the most important. Instead of talking about or over patients, these type of targets and development goals must be developed together. And I'm aligned here with you, Robert. That can be highlighted as one of the things that need to be adapted and brought forward in the future. I think as it stands, it can only be seen as a physician's view and Delphi process that came from different disciplines, as you mentioned, some in epidemiology, some in nutrition, some internists, but it's not the diversity we would like to see with regards to patients and nurses in here, and that will really help us to define what's the target. Maybe we can look at it that way. Maybe it's the physician's way of saying what physicians think is important, and now we got to either do a standalone and look from the other side, or put the two sides together from the very start and revisit that theme. And I think there's a lot of opportunities taking that forward.
I thought the signal went there. You said the three viewpoints there, Jörn, didn't you?
You can say that there are more people missing on there. You don't have the payer's perspective. You don't have the regulator's perspective. Healthcare is so multisectorial that it's probably difficult to get everybody on board. But taking it forward, I think stepwise you can add on.
Just before Michelle comments on that, what I was going to say is when I read the piece, it wasn't so much to me about needing my voice place as a nurse or a nursing professional in it, because it was actually just looking across the broad SDG platform. So it was a place to start. If that's to be developed going forward, then it is the right time to bring the patient's voice, the nurse's voice, the social worker's voice, the other allied professionals, because we're not going to be able to develop a pathway across this framework without all of the purchasing and the buy-in from all of the stakeholders. Personally, when I read it, I didn't take it as a framework. I took it as, where does NASH and NAFLD sit within the SDGs, and now we can move forward. And I don't disagree with most of what went on. It's important to have that discussion because I thought it was a very good piece and I do like the framework, but I think getting us around that table now and people are being aware of it. So I would love people to share this episode with their allied health professionals, because they are going to be part of that network and this framework that was based on the medical and nutritional view. But Michelle, you had something to say, and then I'm going to ask Stephen to see if he's got any comments.
I was just going to really echo that this isn't purely about nursing and the patient. You know, when we look at NAFLD, we absolutely have to recognise that dietitians, nutritionalists, physiotherapists are all absolutely equal partners in this. And one of the problems is that people don't see us as equal. And I wanted to also say that I have now changed my terminology, and I don't talk about multidisciplinary working anymore. I'm talking about interprofessional working, because I think that when I speak to medical colleagues, their recognition and definition of multidisciplinary is not as we would see it, which is actually more interprofessional. And just to say, Robert, thank you for your comment. I do reflect and agree with you. It is about going forwards. There is a slight frustration in my voice because I think we come up against this constantly, and I really want to know, as we say, how we're going to change this.
Stephen, did you have any thoughts when you looked at the piece and how you would measure or the quality in that side?
Yeah, well, sort of Robert and Michelle sort of have sparked an anecdote really in me. So when I help organisations or people together to come up with indicators, so for example, I always say as a top tip really, if clinicians understand why they're collecting the indicators, they're more likely to be collected. They should be involved in developing the indicators, really. You know, that's a sort of a top tip really. And you can summarise this in just one word, and that's co-production. You need co-production. That's really important. And everyone's sort of at the table, and that's certainly what I've been doing for many years. And my sort of anecdote really relates to, I was doing a pathway for HIV. We were all around the table, and I was sitting next to the commissioner for HIV, and we were talking about what we count, and people need to understand what they need to count really. And so some of the indicators that came up were sort of things like people who newly diagnosed with HIV with a co-infection. You know, let's measure the viral load, let's measure the CD4 counts. And the commissioner, who was non-clinical, said to me, well, that's all clinical stuff. That means nothing to me. And when I explained to her that people with co-infections, and particularly if they have a very late diagnosis, you know, from her perspective, the patient is more complex, it's harder to treat, it's harder to manage, and carries a higher tariff. So helping her understand and bringing people along in understanding frameworks and indicators within frameworks is absolutely vital. And co-production is the word. It's, I guess, a hot topic really, and it's certainly something to look at in how to do it moving forward really. But I absolutely agree with sort of Michelle and Robert on that point.
And in fact, that's actually a great point. Commissioners aren't people in clinical environments. So we really have to make these understandable. And I suppose the whole reason for the discussion tonight and moving forward, and we'll go into the next section now about how do we bring that framework. What is that? Is the whole point of late diagnosis in NASH is very common. But you hit the nail on the head. That's very expensive. That's very complex. This is where we need to make commissioners understand that early diagnosis of liver disease is within their interest and the patient's interest, and frameworks like this that cross appear to do that. So I'm going to move to Robert next. So let's start the discussion on framework. Where do you as a patient advocate and patient sit on allied health? Where do you think they fit into the pathway if you had to look at touch points or where people interact, think, feel, function?
Great question. So actually, if I may, I'm not going to talk about now because again, I think we could do it a whole lot better. And I think the answer is, in an ideal world where we were doing this properly, where would they be? absolutely everywhere. How many times have you been facing a patient? And now this could be in a clinical setting, it could be a friend setting, and the patient goes to you, you say, how are you today? And they're like, my CAP score is killing me today. It doesn't. Their pain, their fatigue, whatever symptom, their quality of life issues are what's going to be hitting them, not their CAP score. Or, how are you today? Oh, my ALTs, that just doesn't happen that way. It's about the symptoms and the symptom burden and how that affects patients, particularly the professionals that are allied. So when you look at the much more conversational exchanges that nurses, physios, OTs, dietitians, dentists all have, they need to be part of the conversation. They need to be part of the answer because they have so much to bring. And if we can engage patients where patients are, we're going to find the solutions a whole lot quicker.
Can I just come in? And I think what you're talking about, Robert, there's a phrase called making every contact count. I think this is absolutely where nurses and allied health professionals are there, as you say, in that more conversational but very important role, because we can identify risk factors, we can be promoting liver health in every conversation. And actually, when you look at the workforce, the health workforce, if you just take the statistics for the UK, there is about 593,000 nurses in the UK. So we're the biggest group of healthcare professionals, but we're not being utilised in terms of liver health, because actually that's what we want, isn't it? We want liver health to prevent disease. I have to be balanced here and say it is very difficult at the moment because we know there's a 10% nurse vacancy rate also within the UK. So although we would wish to be across every part of the pathway, there may have to be certain areas where the nurse or the allied health professional is more key, because we just don't have all of those numbers at the moment. Somebody once said to me about low-hanging fruit, and that nurses are a good use in terms of low-hanging fruit because you can find those people. But also I find it quite worrying that people just think, well, that's all nurses are for, because actually we have a very complex role. And as Robert says, we're spanning the whole of a pathway from that very initial primary facing right through to very specialist care. It is difficult because we're all doing more for less. And that is very challenging. But people do forget that there is potentially a very large group of healthcare professionals.
Let me just get in here, Louise, and to mention two things that resonated with me now from the things that Stephen, Michelle, and Robert mentioned. The last phrase may be more for less. It means there's not enough funds in the system to support nurses and give them, either have enough nurses, as you said, there's a shortage, or reimburse the system. And that's something that came out of that SDG paper where we said, it's more funds and resources are needed. And I think they need to go into that nursing aspect to have somebody at the patient sides that can do so much more than a physician that maybe discusses some hard facts or some diagnostics or maybe the next therapeutic steps. And looking at from Robert's perspective or the patient's perspective, of course, is what comes up with me. And Robert, maybe one of the things that we've missed as physicians in the past is the empowerment of the patients. Now, it's difficult to empower each patient and educate them about, as you said, the CAP or the ALT. Most of the time, that's for many patients, it's over their heads. Some want that information, some don't want. It's difficult for a physician to find that out if you have a short time of contact. But I think that's where of course, patient advocacy comes in and is there to inform and support patients and empower them to be, when they're talking to the physician, to know what they should ask or what are the crucial measurements the physician relies on in assessing the patients. And that's also needed. And I think that was part of that paper that we brought forward saying, we need resources and the whole discussion's got to involve that. So that's been said without the involvement of those professionals. Revisiting that theme, but I just thought these two aspects resonated with me when I listened to your comments.
Can I say something just on sort of the back of Michelle, really? I'm having the same conversation in heart failure at the moment. So I'm doing a pathway for the British Society for Heart Failure. And I'm doing also some work in rheumatology, and everyone is fighting their own corner. Everyone's trying to fight fight for their disease, and everyone's saying, how can we do this and how can we do that? And the way we've resolved this, certainly for heart failure, because the question that was asked of me was, how do we raise heart failure as a differential diagnosis higher up in the clinician's mind? And the reason for that is 80% of people with heart failure diagnosed in hospital. Of those 80%, 40% have had symptoms and visited the GP for 2 years. And they're presenting, they're decompensating, they're in an acute state, and they're a later diagnosis, really. And you can talk about another disease with almost the same sort of pattern, really. And so everybody wants to fight their own corner. And what we've done in heart failure, we've thought, right, okay, so we've thought of three things. Where are the settings where we can find people? So primary care, for example, A&E, a community clinic, etc. And what are the opportunities are there where we can capture people? And then we thought, well, what type of people are we going to capture to get our highest yield? And so we've prioritized our list. So, for example, obesity, diabetes, COPD, AF, there's another one we can't think now. But if we say in these settings and in these opportunities, if you have someone with these existing conditions, obesity, diabetes, and they have swollen ankles or they're breathless, please think of heart failure higher up the agenda instead of having this, everyone needs to think about heart failure blanket approach. And then what we can do is, to answer your sort of question, Michelle, is then you can sort of target your workforce then to make every contact count. I have these conversations, I can see the same problems in different disease areas, really, and everyone has the same sort of passion, but it's just about discipline and realising that, as you say, 10% deficiency in the workforce in nursing. It was just a reflection.
No, it's an excellent reflection, because I'm now going to bat the ball back. At what stage in the communities that you have just described in heart failure did you have the discussion about fatty liver disease? Because they sit in them all, and locate the fatty liver disease before you get the heart failure. This is where we're talking really upstream. Because if we locate that bad liver and poor liver health, 80% of those patients don't get diagnosed in casualty or in hospital with heart failure. And I bet it didn't come up because they're all the same population. What we're trying to do is target earlier all populations, because poor health in the liver sits below them all. And this is the framework. It's that diabetes nurse or the GP primary care nurse, exactly what you're discussing, having a general discussion about your blood pressure, your this, your diet. Oh, and how's your liver health this week?
I mean, these podcasts obviously are certainly helping, but I'm sure everybody listening to this podcast is interested in liver disease. It's about how you get that out to the generalist. I said in my introduction, because of my A&E background, I am a generalist. I've worked in primary care, I've done community, I've done A&E. I'm a generalist, really. How do you get somebody like me in clinical practice to think about heart failure, think about liver disease, think about all these things that people are not thinking about? Your swollen ankles, right, or you're breathless, that must be your chest then, that must be your COPD, and ignoring the fact that, trying to triangulate these symptoms. Good point. It's trying to find that way, really, through, because, you talk about pathways. If you did a pathway for NAFLD, fatty liver disease, then the specialists aren't going to use the pathway. The specialists are the authors of the pathway. You know what to do. You know when to refer. You know what blood tests to do. You know how to manage the patient, really. It's the generalist, it's the practice nurse, it's the GP, it's the community matron, it's the junior doctor on the acute medical assessment unit. These are the people that you need to reach, really, to grab the generalist, really.
Go on then, Michelle, jump in.
Well, I was just going to say, it's interesting when you're speaking about that, Steve, because actually, when we look at risk factors for liver disease, it's people who are overweight, with obesity, have diabetes, cardiovascular risk, maybe drink a bit too much. But when you look at that, that's everything that, in a sense, it is being asked in primary care, but it's not being translated into these risk factors for liver disease. People just think, well, this is a problem in terms of diabetes, this is a problem in terms of cardiovascular risk. And it's about, again, trying to, and we can talk about education constantly, but people have a set amount of time to spend with each patient, but it's how do we to make this a multi-comorbidity assessment.
Robert, can you jump in on what's the view? What do people really feel that they need in these assessments? Is it just one thing and then get targeted, or do they want people to pick it all up at the same time? Because Michelle's right, that we do ask those questions and they are done very well in primary care, but they're not connected.
So this is where clinicians and everyone who works in the field has my sympathy. Patients are whole people. If you have NAFLD, you don't just have liver disease. As Stephen was alluding to earlier, if you have a heart problem, you don't just have heart disease. And this goes back to the very first conversation we had, where we have a wonderful paper that's taken in a silo. We need, as patients, the entire community to come together and not just think about heart disease, not just think about liver disease, because we as patients need more than one therapy, more than one organ being monitored, and more than one answer to our questions. Now, how we produce that is a much, much bigger conversation. I'm not sure we have the scope or timing tonight to do that, but I think it's important to start raising those questions, and this is where people like Jörn can lead from the front, and when they produce a beautiful, helpful paper, by being more inclusive, you're setting the standard for best practice. And so when we come together at conferences, I would love to see heart specialists talking at EASL about NAFLD and all of these kind of things, where we start to bring in the other experts and bear in mind that first and foremost, patients are whole people. And I know that complicates things, and I know it makes it so much more difficult, but we're never ever going to get around that. So we're just going to have to address it.
Well, one important aspect here, I think, in clinical medicine is that we do have less and less generalists, as Stephen calls himself. Of course, everybody is super specialized. That complicates, and I'm aligned with you here, Robert, certain, intersectoral cares. And maybe circling back to allied health professionals, the nurse sits in the perfect spot to combine all these experts and funnel that back to the patient and guide him through those and through the system. One of the things that came out of our Barcelona meeting on the patient pathways was that there could be dedicated nurses or patient-to-patient peer advisors that actually guide patients. And I think that could help partially overcome some of that specialization we're seeing in clinical medicine today.
Yeah, and I think you can plug next year's, because you've just announced the dates, haven't you? And it's a hybrid meeting in May, if I remember correctly.
That's right. It will be end of May next year. Please mark your calendars.
So we did want to come back for more, but I was drawn to a comment or something that I looked at earlier on this week, and it's a new white paper by IQVIA on challenging in digital health. They opened with a beautiful statement. With changing healthcare dynamics and technology reshaping customer experiences, the patient has now become the centre stage on care continuum. Patients have transitioned from being decision followers to decision influencers. The empowered and powerful patient is on the rise. That was such a beautiful statement about where patients are now forcing, and obviously we've got patients and patient advocates like Robert, Donna Cryer, who fulfill that definition of you need to be involved in writing the pathways, and that advocacy at a senior level, Robert, is really powerful in the liver forum, as it is in lots of disease processes. HIV was obviously a very big push in the 80s and 90s. It's only going to get stronger, and I think there is, from what I can gather, a big momentum, particularly in fatty liver disease, for example, for pharma to take that into account as part of their pathways, because, as you rightly said, the patient doesn't just have one disease. But we're pushing strongly at the doors to say, if you've got a drug that targets one of the main risk factors, is it appropriate that you start looking for the patients at risk of the other risk factors and diseases? So that holistic view. Stephen, I'm just going to come to you slightly on this, because you were part of a programme which I think was for HIV, which was 90-90-90. Now, explain that pathway to me, because I thought that was something that might be of interest in liver disease when I was thinking about it.
Okay, can I just pick up on a point first that Robert made, really, which I thought was sort of quite interesting, really. So my thoughts really around, about sort of getting people involved and getting a cardiologist to speak at a liver event. I mean, that's just like super, that's really, really good. But if you want people to do something, for example, if you want people to measure something, an indicator, an outcome, and ask people to do it, they might do it. If you ask them to measure and report it, you get a greater uptake in people people reporting the indicator. If you ask people to measure, report it, and they get performance managed on it, then you get a higher uptake and people sort of tend to do it really. And then if you get people to measure, report, performance manage, and they get paid for that, that's when it gets done. So you can have all lovely reports and you can have lovely, great conferences and stuff like that really. If your national framework does not include something that makes a significant difference to commissioners and providers, then the stuff that does will take over. You know, it's like, that's really, really important. Liver disease is really important, but I'm not being performance managed on it. It's got nothing to do with my finances. However, this dementia is, you know, we've got 2-year waiting list on dementia. We need to get more people diagnosed, blah, blah, blah. Right, okay.
I think that's a very fair point that you make. And just to say that the UK Liver Alliance is really pushing at the moment, because there is a recognition that GPs don't get paid in terms of looking at liver health, and that will aid earlier diagnosis. However, we're going to get that with earlier diagnosis, but really we want to be preventing liver disease, and that's why that public health agenda is really important as well.
Absolutely, 100%. To answer your question, Louise, just sort of take you back where the HIV work I was involved in, which is a global success really. It's about identifying the most important measures across a pathway. So I think of a pathway, I think you can measure a pathway in 3 different ways. I think you can measure the high-level steps across the pathway. So if you've got, say, for example, prevention, just as an example, prevention, diagnosis, management of chronic, management of acute, advanced therapies and palliative care or something like that, really. You can measure those high-level sort of steps. And then you measure the indicators within each step. So around diagnosis, you could measure a number of indicators. And then what the HIV experts have done is that they identified about 3 or 4 indicators that distill absolutely everything that you're trying to achieve and made it a global language. So it's called the Fast Track City Initiative. As I said, it's a global success. And they started out with this basic concept of 90-90-90. So you get 90% of the people that you know of in your area with HIV diagnosed and know their status. Of those 90%, you get 90% on treatment and retained in care. And of those 90%, you get 90% with a suppressed viral load. So that means that they can't transmit the virus. And then if they can't transmit the virus, then the final indicator becomes a great public health indicator because they're preventing HIV. So it's called the 90-90-90. It's that successful. The indicators are now 95-95-95. The higher the percentage you go up, the harder it is to sort of find people, engage people in care, really. And so HIV is a very complex disease. There's lots of indicators that apply across the pathway from psychological care to bone health. But what's more important than getting people diagnosed, getting on treatment and suppressing the viral load? Now, I've sort of had this debate with Louise and asked the question, can this concept be replicated for fatty liver disease? And we've both concluded that the answer is yes, you know, and to prove you can take it from a communicable disease area, I've just replicated this in another disease area, and we actually start next year, and it's already starting to grab global attention, really. It's that successful, a universal language. I could phone up a city in Africa, in the Far East, in South America, North America, and I can say, what's your second 90? And they know what I'd be talking about. They might say, oh, it's 89, or ours is 94, or hey, we hit our 90s, you know. It's a fabulous concept. The concept is simple, and that's the beauty of it. It's a simple concept. I think it would work in fatty liver disease. It focuses the attention.
No, we didn't quite think when we were discussing it, to be fair, that we could go for 90% of people with fatty liver disease diagnosed.
Yes,
we
yeah. We thought
there.
yeah. So 60, 70, 80, wasn't it? I think. Yeah, but that was the idea in HIV. It was just fabulous. It started out with 16 cities, and there's now over 400 cities worldwide that have signed up for this. And that, as I say, I've transferred this to another disease area. I'm currently building the platform for it, and it could be used in lots of different disease areas, really.
I liked the simplicity of the thinking behind it. You could do it, Jörn, when I think about it, when we discussed about the clinical trial failures last time and the struggle to get people into trials, finding that 90% of the population who are eligible and getting the numbers better for who's going to get in. So I could visualise this sort of pathway and simplicity in anything. either I want as a nurse to have 90% of my patients engaged in the care. Of those 90% that get the care, can we suspend and get them on the pathway, can then concentrate on the 10% who are probably deteriorating, heading towards transplant and things like that. So that type of thing I could visualise in a lot of the work that myself or allied professionals have done, and quite a simple. I couldn't believe it when I was thinking, I thought that could work. Any other comments from others?
Just to add on, it resonates with me, Stephen, and the good point is, of course, that's been established, right? So you can recapitulate that and physicians relate to it. That's my quick thought.
Yeah. I mean, I know, Michelle, absolutely 100% agree with you that prevention's most important, but we do need to find people. And I mean, I just sort of scribbled down here, maybe as a young adult, you find 90% of people, and they have a criteria. So 90% of people with type 2 diabetes with a BMI of over 35 are identified for a FibroScan. Of those 90%, if they're diagnosed with fatty liver disease, 90% are on a treatment pathway. Of those 90% on a treatment pathway, blah, blah, and then whatever your outcome would be. So you can actually play around with the figures and play around with the idea. It's a great concept. It's simple. I'm happy to discuss it further and take my learning. I've taken this from a communicable disease to a non-communicable disease. It's great.
I was just going to say, it sounds very interesting. And I think, as you say, you can use sort of different parameters, can't you, for different patient groups, risk factors, etc. So, I mean, it's something that I certainly will be doing some more reading about. Yes. Thank you.
Robert, is it something that if you said I was diagnosed with X, I now want to be the 90% of I know where you're trying to get to this? Is it something that would resonate to say that I've been diagnosed, now I want to be the person who gets to the best lifestyle advice and stuff, and now I need to be the next 10 that would do this? Is that something that you can see?
I think it's a great question. I think it's a great concept. So it feels, just within this 2-minute section, that it might be the next way forward in terms of digital health. Because one of the things we talk about when we talk about digital health is the gamification of it. So if you are able to get your diagnosis and then you're on your treatment, and then you see that you're in the 67th percentile of whatever measurement it is, that's a motivation. And you think, actually, I'm just going to push on. I'm just going to go and really go for this. And then you get you to the 72nd percentile. That's a really nice way, because ultimately, when we're still looking at NAFLD treatment, self-care is everything. And so the more motivated we are, the more supported we are, the more empowered we are as individuals, the better we're going to do. It's a cracking idea, and to have those kind of concepts in place, I think would be enormously empowering for patients.
It resonates with me because you can define goals. The aspect Robert mentioned, the gamification, I like that because it's a motivator for patients, it's a motivator for health professionals, and it allows you to rank also your service and what have you achieved and where can you refine your service maybe, or you offer that for the system, or as an individual, where do I have to work myself up. So I think it's an interesting, again, the numbers in the non-communicable disease area, it's a little tougher for the outcomes, but as Stephen mentioned, patients going onto a referral pathway or having certain checkups completed, that could be one number of interest for these patients as far as we've defined quality of care for them today.
Absolutely.
Yeah, absolutely.
There was a lovely piece in, going back to the original paper, that was about education, and it was about the fact that there is no liver education in schools and liver health isn't engaged at a school level. And maybe that's what needs to change. A lot of schools have to do health checks on children within their concept. So actually maybe adding liver health as an outcome, or certainly a discussion with the growing risk of obesity, cardiovascular problems in children as they get older. Is that somewhere that this sort of framework could engage in the community? Because if we start that conversation earlier, liver health isn't then something that people aren't aware of. Because I think, as Stephen said, engaging a cardiologist in liver health or primary care, it's not at the top of agenda. But if it started a little bit earlier, which I think was where that part of the framework, when I read that work, took me, that's maybe where we should be now, engaging as that level in the SDGs, that education.
I was just going to say, I think that's really important, Louise. And we always talk about the next generation, don't we? And we already know there are some dramatic statistics statistics around children who are overweight or obese already, and those percentages are absolutely terrifying because we are building the next generation of people with NAFLD already. It's interesting to think about it, as we say, as a more focus on liver health maybe in schools. I wonder whether the pushback might be that, well, we talk about healthy eating and we talk about exercise and we talk about alcohol and we talk about drugs. You know, those four concepts areas are related to most of the risk factors for liver disease, aren't they? Absolutely. When we look at the percentage of children who are now overweight and obese, we have to do something, and maybe this is possibly something that we could use as a concept.
I had the pleasure to meet a liver social worker specialised for hepatology in the US when I was recently there. We never get access to stuff like that in the UK that I'm aware of. It's so valuable given the social problems that a lot of patients have, or the psychosexual problems, or any of those that really need a different target. So how broad do we go on allied health? Do we absolutely need specialist allied health, or should we have specialist allied health? Jörn, do you have a social worker in Germany?
We do, but it's heavily focused on inpatients, obviously. Working in a hospital-based system, that's where the revenue for the system is generated, and there's a strong focus on inpatients. Now, in the outpatient, it's much more complex. That's offered. It's run through the primary care, so it's nothing that I can directly prescribe as an expert, and I have to always refer the patient back to the primary care, as the whole system in Germany is somehow primary care centric, where he sends them off, gets some opinions, and then collects everything, and stuff is run through the primary care physician. But as we all know, there's not a lot of time for the primary care to focus on all these different aspects. So while I think it's important, I'm not sure that in my setting that's the way forward, and I don't have funds at this time. But revisiting the theme of the Sustainable Development Goals, I think this is one area that also could be defined, where we point out that more resources and funds are needed.
Oh, absolutely. Robert, do patients feel that there's a lack of social resources in the system, and people who have that specialist knowledge, particularly now we're in a sort of credit crisis, lower incomes, higher inflation rates, how much pressure does that put on?
No, it's a great question. If anyone's had the misfortune to hear me present over the years, you'll know I talk about a number of, I have a few drums that I like to bang, and I do so because they're important. One example being that as long as the donut is cheaper than the apple, we're going to struggle to implement change. You know, when we are asking patients to conduct psychological warfare against manufacturers such as Kellogg's, Coca-Cola, other manufacturers are available. You know, we could there's a list there. Now I just pulled out the two that are at the top of my head. But whilst we're asking patients to singularly conduct that warfare and fight the might and genius of the advertising industry, we're never going to implement change. And so it has to be coordinated. There has to be social aspects to this. And we absolutely need to come together as communities. So it's not a one-on-one fight, because it's not a one-on-one fight. And the stronger we are together, I think the more chance we've got. Sorry, on you go.
When you were describing that there, you were describing the SDG, I think it's number 2, which is hunger, food, malnutrition, including obesity, the eating. So I think the framework leads us into the natural discussions. And when you pick out the points, it leads us back to the framework, which is why I do like it as a basis that people should look at from that interconnection. When I was reading it, it was also about what questions do I assess patients with. I should be asking, if you want to do exercise, do you actually live in an environment that allows you to safely go and exercise? That's what it pulls me back to. A more holistic assessment of a patient or the environment that they live in. And I think that was done very nicely.
Yeah, you're absolutely right. Is it safe to exercise? Can you afford to exercise? Do you have childcare so you can exercise? There are so many social aspects to that, just that one simple question. And you're absolutely right. We need to be hammering down to this level of detail to support patients in their own journey. You bang on the head there, Louise. Thank you.
Can I go from that detail,
of course you can,
which is absolutely right, to the other end of the scale, where how do you get these sustainable goals embedded in NHS England or in a health system? If it doesn't filter down, I'll just talk about the UK, but if it doesn't filter down from the Department of Health to NHS England to integrated care boards, integrated clinical systems to GP land. People are just too busy with other things. How do you make that sort of step? Because that detail that Robert's just spoken about is absolutely crucial. They are the barriers that stops people exercising, but it's on a continuum, and you need to get it in somewhere. There needs to be an in somewhere within the NHS.
And that's exactly the point. That was the question we started with at the beginning. Is every government apart that's in the United Nations and the WHO has signed up to the sustainable deliverable goals, and we do not get it we don't get it at the front line. It's not in NHS England. So how do we deliver the improvement that requires? So you're exactly right, Robert.
So a couple of things, if I may. So I'm going to shout patient organisations. So I'll put that out there and I'll come back to it in a second. Now, you may or may not be aware. Now, I'm going to forget his surname. It's Dr. Mike, and it'll come back to me. And he was a Canadian physician who did an animation called 23.5 hours. And it's available on YouTube, and it's an immensely powerful piece. And I discovered that through working with a heart unit in Dundee. And just that 5-minute video was enough to start to address the barriers. And, that was one unit who then, through conferences and everything else, led and shared it with a whole lot of other units. On these kind of topics, I think the patient support organisations come together. I think it was Jörn that said earlier that, patients talk to patients. And you're talking about your patient buddy system. We are an inbuilt patient buddy system. When you talk about the fatigue where you feel like the power's been pulled, or when you're talking about an itch under the skin, another patient's going to understand how that feels. And that connection is there, it's instant, and it's permanent. And again, it's another powerful route to engagement. So to answer Stephen's point, and again, it's a great question, but I think the more, it goes back to what Louise said about right at the start, the more we work together as entire communities and bring all the stakeholders in and the power that they hold, we've got more chance of cracking this.
Stephen, you want to say something before I start to sum up?
No, peer-to-peer absolutely works, and there's fabulous evidence in peer-to-peer breastfeeding support, which helps both in initiation and long-term breastfeeding, which improves outcomes across the board. So the evidence base is there, and that was something that was supported by NICE, the National Institute of Clinical Excellence, really. But getting people around the table and getting people together, there needs to be, not authority as such really, but there needs to be some support given from above. I do believe that. I've seen lots of enthusiastic people, lots of enthusiastic subjects discussed, but without that sort of rubber stamp that it's okay to go forward and do this. You're treading water. People just keep doing, but they're just treading water really. And it's almost like, we haven't got time to sort of share this, but if you can read, I can share the paper, but if you read about the North Kareli behaviour change model, where they made amazing changes in reducing cardiovascular disease in Finland. That's just a fabulous example of actually working with patients face to face, but working at government level at the same time.
Fantastic. We'll put that on the website as to what the link is so that people can do that. But we are now well over the hour, so fascinating discussion, and thank you very much for everybody. So I'm just going to go round clockwise on my screen and just ask you what you're going to take away, and just briefly the complex bit of where we're now going to head to get allied health into these pathways, because whilst we've got a framework here, moving it forward is going to be interesting. So Michelle, your take on what you've taken out of today?
I suppose I've clearly articulated where I feel nurses and allied health professionals and patients need to be in this. I think personally for me, I'm very interested listening to others about these different approaches. So the 90-90-90, I'm off to look at Robert's animation, this behaviour model from Finland. I think it's about educating ourselves as well, isn't it, about all of these different opportunities. And this discussion lends the fact that people come at it with very different backgrounds and information to give. So I'm very interested to look at these resources and think about how they might be able to make an impact.
Fantastic. Robert?
Thank you. First takeaway, this is always a pleasure and always an education. Second takeaway, there's incredible work being done, and I think that the sooner it comes out of silos, the better. My last takeaway is that there is an immense knowledge base out there. And for us to crack this, we need to come together as a unit, because there's so much that we've learned from each other just in this 1 hour. And if we were to work meaningfully together, hour after hour, day after day, we would learn so much more and we would get to the answers much, much quicker. So those are my takeaways. Thank you.
Fantastic. Thank you, Stephen.
Well, first of all, thank you very much for inviting me, Louise. It's been great. I'll be truthful, this is my first podcast, so I was a wee bit nervous. But anyway, I promised to send you the Pushka paper on the North Karelia behaviour change model. I'm open invite to talk about the 1990 concept, and I've translated that to another disease area. I'm happy to do that. And I will think about how to get liver disease higher on the agenda, because I work across different disease areas and stuff, really. Someone's done this before somewhere else, so I'll try and have a little think and see if there's something that you can sort of translate. Might be something in dementia, I think, off the top of my head, but that's what I'll do. But it's been good discussion and lots of learning, and a pleasure meeting you.
Jörn, so I don't think we've necessarily nailed down how the pathway is going to move forward, but we've nailed down that we need to be all over it like a rash. So what were your takeaways?
That's a good learning, right? And I think the pathway moving forward to develop needs a lot of players, and Robert, Michelle, and Stephen helped me to break out of my physician's cocoon, which is of course difficult because you have to then face the patient and leave your home grounds where you're comfortable with all your diagnostic tests and leave that dysymmetric communication, of course. It's always great to exchange at that level, and I'm very glad and thankful for the honest and open feedback here. And I think we can make things better and actually develop something for patients, with patients, supported by nurses, and in the end promote liver health. And that's very reassuring for me.
Fantastic. And I've just loved listening to everybody's views and just getting the insights. The pathway itself and the development goals and what it's based on actually transcends different areas. And I think that was the beauty of it. And I think, as Robert and everybody suggested, the difficulty is now is how do you develop that? How do we help you develop that as a group and as a forum to put the meat on the bones in each of those that's got an achievable target that we can do? And there's been some great suggestions and some great learnings from different areas. So I hope people enjoy this. It's also about opening our minds to how broad we have to be. When somebody does a questionnaire and takes something and does market research, you're only getting a snippet of that market. The real strength is the breadth of knowledge that allied health bring to the whole picture, because you can't build a jigsaw puzzle of 1,000 pieces without 1,000 pieces, because there's always one missing, and it's the one you need. But thank you for everybody today. Stephen Callaghan, Robert Mitchell-Thain, Michelle Clayton, Jörn Schattenberg as ever. My co-Sophie, Roger for letting us loose for a week and that, but our team, Magic Mike, Eric, Steve, Murph and James, our new producer. So Roger, I think, has recorded the business section, and if not, I will do that at a later date so to give you the thing. But share it with your allied health professionals. Everything we discuss on this podcast is suitable for any allied health professional to be part of that discussion, because those professionals will pick up clinical trial patients, they'll get patients to the next step. So share it with your nurses, encourage them to come on and listen to it, because they need to be part of the discussion as we've been part here. And I love the work that Jeff Lazarus, the team did, and Jörn on this piece of paper, and with this publication. It's a great framework to start. We've enjoyed the discussion around it. So thank you very much for everybody, and we'll see you next week, and it will be Roger back in charge and in control. So thank you, everybody.
Thank you.
Louise. Bye-bye.
And now for the Season 3, Episode 42 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to the heroes. Enough said about that for this week. Normally, I record business sections right before we post our episodes, but since I'll be on vacation when this episode posts, the business report will be brief and will anticipate what's to follow. More complete information coming when I return next week.
Our second installment of our Rising Tide in Diabetes series went live last night.
As I mentioned last week, this episode discusses the guidelines released from the American Association of Clinical Endocrinology, or ACE. Our panel includes the lead author of the guidelines, Dr. Ken Kuzi, the third author, Dr. Deanna Barb, and the two AASLD representatives in this exercise, Drs. Maru Ranella and Zobair Yanasi. They discuss the factors that went into developing these guidelines, the key takeaways, and how they suggest these should be used in practice. The target audience is physicians and allied health professionals who have patients with type 2 diabetes or obesity as a large proportion of their practices.
This week's Vault episode harkens back to the last time Louise ran the podcast.
Our Vault episode this week is from February, the last time I was off and Louise moderated the podcast. It focused on the role nurses play in patient education and why this is so important for patients with NAFLD or NASH and other metabolic diseases. I'm not sure, but I anticipate it will tie in nicely to what we will be discussing in episode 42.
Roger is off this week.
As I just mentioned, I'm trying something completely new, a total week away from the podcast. Heartfelt thanks in advance to Louise for organizing and leading this episode and to the rest of the team, particularly our new associate producer Jake and Magic Mike, but also Eric and Steve for getting this out without my active participation. I'll be back next week with Stephen Harrison, Naeem El-Khoury, Mazen Noureddin to discuss combination drug therapies and their likely role in the future of treating patients. And with that, I'm off. I already thanked the crew, so thanks to you for making this such a worthwhile labor to pursue and for sticking with listening and all those good things while I'm away. Remember to look on the Surfing NASH website for the links to the CME pilot and the new Rising Tide episode. Stay safe, surf on. I look forward to seeing you next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com and we will answer on the podcast or the website.